In this video, we'll be talking about some common BLS or EMT interventions for various medical conditions. First, we'll start off with respiratory conditions. Remember that if you've got a patient that's exhibiting signs of respiratory distress, signs and symptoms of asthma or COPD, which would more than likely present itself with a patient who is having a lot of difficulty breathing. They may be tripoding, helping to hold their chest open, using accessory muscles in between their ribs, around their collarbone, using pursed lips, may not be able to speak at all, or they may be able to speak in one or two word sentences. Those are all signs of some pretty bad difficulty breathing. When you listen to lung sounds, you very well could hear wheezing, especially expiratory wheezing, which would be signs and symptoms, once again, of an asthma attack or exacerbated COPD. As EMTs, we may be called on to assist a patient with their albuterol or rescue inhaler. If we do that, once again, for testing purposes, we want to call medical control. Depending on where you're at, your protocols may allow you as an EMT to do that without calling medical control. And you may be able, as an EMT, to give nebulized albuterol from the drug box. But for this, we're going to go over the rescue inhaler. Remember, when you assist somebody with a rescue inhaler, you always want to shake it up. You want to instruct them to exhale completely, put it up to their mouth, make sure they make a good seal. As they inhale and take as deep of a breath as possible, you would squeeze it to give the puff of medication, and then advise them to try to take in a full deep breath and then try to hold it for 5 to 10 seconds. That will allow the medication to go deep down, because that's where it needs to get to do its job. This doesn't do any good in the back of the throat. So you want to make sure they, once again, shake it up, seal, inhale, squirt, hold, continue inhaling until they can't hold anymore, then hold their breath for 5 to 10 seconds, and then exhale. So that's how we would handle that. And of course, we would put those patients on oxygen. If they're having a lot of difficulty breathing, we would give them high flow O2, 15 liters per minute, oxygen, non-rebreather. All right, let's quickly talk about nitroglycerin. Once again, nitroglycerin for patients who are having chest pain or chest pressure that you believe to be of cardiac origin, and you may be able to assist a patient who has their own nitro. Once again, some EMTs in some areas, depending on your local protocols, may be able to get nitroglycerin out of the drug box and administer it. But for this purpose, we're going to talk about assisting a patient who has their own nitro. So if you've got a patient who is exhibiting signs and symptoms, chest pain, chest pressure, and you believe it to be of cardiac origin, and they have their own nitro, for testing purposes, once again, you want to call med control. But a few things you need to make sure of before you consider giving nitroglycerin, even if it is the patient's own. First of all, you want to make sure, go through your 5 rights, and that goes through any of these medications: right patient, right dose, right route, right time, and you're giving it for the right reasons. So in this case, nitroglycerin, the 2 contraindications, major contraindications, is a systolic blood pressure below 100 for EMT curriculum, and if they've taken an ED or erectile dysfunction drug within the last, if it's Viagra, within the last 24 hours, and if it's one of the longer acting ones like Cialis or Levitra, in the last 36 hours or day and a half. If their blood pressure is above 100 and they haven't taken one of the ED drugs in that specified time, then we would call med control to assist, and we would give med control a report of the patient's vitals and condition, and then we would assist them. When we give nitroglycerin, if it's the tablet, it's 1 small white pill under the tongue. They don't swallow it. It just needs to dissolve under their tongue, so let the patient know that. And then if it's the spray, it would be 1 squirt under the tongue. Once again, let it dissolve. When cardiac patients, I don't have any aspirin here, but another important drug to give even before nitroglycerin is aspirin, low-dose baby chewable aspirin. That acts as a blood thinner and is important to give in cardiac patients. But once again, the 2 contraindications there is they can't be allergic to it, and they can't have any active GI bleeding, so especially upper GI bleeding, a stomach ulcer, something like that. Esophageal varices, where there's like varicose veins in the esophagus that are bleeding. That would also be a contraindication. So with aspirin, If they're not allergic to it and they don't have active GI bleeding, you would give 2 to 4 low dose, which is 81 milligram, chewable baby aspirin. And once again, you would give it to the patient, let them put it in their mouth, chew it up, and swallow. Let's talk about hypoglycemia. This would be a blood glucose level, usually less than 80. A lot of times it'll be way lower than that, 70, 60, 50, 40. When we have a patient that has an altered mental status and we check their blood sugar, maybe they're diabetic, maybe they're not. People even that don't have diabetes could possibly, under certain circumstances, have hypoglycemia. But a lot of times it will be a person that has a history of diabetes. If they're awake enough to protect their airway, then we can give oral glucose. This is about 15 grams of sugar in a gel format. The ideal way to give it is actually to squeeze it in between their gum and cheek and allow it to absorb. I know some patients will swallow it, but you can just squirt it in between their cheek and gum. You can put it like on a tongue depressor and spread it in that area, and that'll work just as well. Once again, if their blood sugar is low and they've got an altered mental status, oral glucose would be the treatment of choice. Also getting ALS on the way to possibly start an IV and give them D50 through their IV. But for BLS, oral glucose. If you don't have oral glucose available, you can have them drink a sugar solution or any solution that's got sugar in it, such as orange juice, a soda. Just make sure it's not a diet soda. It's got to be an actual sugar soda that has real sugar in it. Let's talk about anaphylaxis and the EpiPen. If you've got a patient who has their own EpiPen and they're exhibiting signs of anaphylactic reaction or anaphylactic shock, which would include hives plus any of the other symptoms such as difficulty breathing, swelling of the airway, swelling of the tongue, swelling of the face. Another common sign, believe it or not, of anaphylaxis that isn't advertised a lot is really bad GI upset, vomiting, diarrhea. That's the body's attempt to hurry up and get that thing that they're allergic to out of their body quickly. Low blood pressure, altered mental status. So if you've got a person that's just got hives and itching, that's probably just a bad allergic reaction. Once you start to develop some of these other signs and symptoms along with that, once it crosses over 2 body systems, so once again, swelling of the face, swelling of the tongue, itching in the throat, swollen lips, swollen face, eyelids, low blood pressure, altered mental status, GI upset, any of those, then we want to assist them with their EpiPen if they have their own. Once again, for testing purposes, state testing, we want to call med control very quickly. Remember the way the EpiPen works. You pull the blue tab out of the top. That's kind of a safety. It won't fire as long as that blue tab's in. Pull the blue tab out of the top. It's designed to go halfway between the knee and the hip on the outer thigh. You can put it right through a couple layers of clothing. Pop it in. Hold it for 10 seconds. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Pull it straight out. Dispose of it in the Sharps box, and remember to massage the muscle to help it absorb quicker into the bloodstream. Remember, epinephrine is going to combat the difficulty breathing, help open up their airways. It's also going to combat the low blood pressure and probably the altered mental status that may be coming from the low blood pressure or poor perfusion by constricting the blood vessels and raising the blood pressure, and then also reducing swelling in those areas all throughout the body. But it usually happens pretty quick, and once again, these patients need to be transported because they could have a secondary or rebound reaction once the epi wears off. They may need another dose, and they may need some other medications like steroids and that sort of thing. Some other things, stroke. Somebody's exhibiting signs of a stroke, such as altered mental status, slurred speech, droopy face, weakness, paralysis on one side of the body. We would be thinking possibly CVA or stroke. Remember, there's 2 types of strokes. About 85% of strokes are the clot type of stroke or ischemic stroke, and about 15% are hemorrhagic, or where a blood vessel in the brain actually pops and lets blood out into the brain. Either way, unfortunately, as pre-hospital providers, there's not a lot we can do to actually treat the stroke in the field. It's mostly supportive care, protecting their airway, protecting their weak side from further injury. But we do want to, it's very important to remember to, one, check a blood sugar, make sure their blood sugar is okay, and that the symptoms, altered mental status, isn't coming from that, so we can rule that out. And then two, remember, we want to try to pin down exactly when those signs and symptoms started, or when did family or somebody that can verify when were they last seen normal, because remember, that's going to be important information to the hospital, because that's going to vary which way they treat the patient, risk versus benefit thing. If the symptoms occurred within if they can get treatment within a 3 to 4 hour window, then they usually get high power clot busters. Outside of that window, they may just observe or try some other treatments. Also remember, with the stroke patient, you want to assess their neurological condition, first through PMS, pulse movement sensation in every extremity, and then we want to run them through the Cincinnati pre-hospital stroke scale. The first thing we want to get them to do is ask them to smile really big or show us their upper teeth. And once again, when they smile, we're looking to see if one side of the face droops or doesn't raise as much as the other. It'll usually be pretty obvious. The other test is we want to have them hold their arms out in front of them, close their eyes, and then you can count to about 10 for them. But you're looking for, this is the arm drift test. You're looking for any weakness or movement on one side of the body. They pass the test if they keep it still, or if both arms kind of drift the same. What would be failing the test would be something like this or this. The third and final test of the Cincinnati Pre-Hospital Stroke Scale is asking the patient to repeat a phrase. The common phrase that we normally use is, "You can't teach an old dog new tricks." So as they repeat that back to you, can they repeat it back just like you said it, or do they have slurred speech? Do they have confusion? Do they mix the words around? Any of those things would be failing the test. If a patient fails any one of those three parts of the Cincinnati Pre-Hospital Scale, they say it's about a 75% likelihood that they're having a stroke. So it's a pretty good indicator. A few last medical things you could run into would be abdominal pain or abdominal symptoms. Once again, a lot of that's going to be supportive care. Remember, you do want to always check vital signs in all of these patients to assess their status and get multiple sets to form a trend. Are their vital signs staying stable? Are they going down? Are they getting better? So we want to form a trend. If we have abdominal pain or abdominal symptoms, we want to lift their shirt, view that area. Remember to look at all four quadrants. Remember to palpate all four quadrants, and always to start, if they're having pain in one certain quadrant, do that quadrant last, because if you assess that one first and it hurts, you're probably not going to get to assess the other three that's going to hurt too bad. So always start at the quadrant away from where the most pain is and work your way around to the area of the pain. You're also looking for things like distension, bloating, rigidity, which could tell you that the patient could have internal bleeding. But that's how you would handle an abdominal pain. It's mostly supportive care, allowing them to find their position of comfort, which a lot of times will be kind of balled up in the fetal position, kind of protecting it. So that pretty well wraps up some of the more common medical conditions that you'll run into in real life as an EMT and in testing as an EMT, and how you would handle them, and making sure that you rule out those contraindications before you decide to give or assist the patient with the medication. Thank you.